The defining feature of myasthenia gravis is a highly specific kind of physical fatigue. Skeletal muscles function normally at rest, but with repeated use, they give out. The eyelid droops against the patient's will, a condition known as ptosis, and simple motor tasks become impossible. This fluctuating weakness is the result of an autoimmune misfire. In a healthy body, the immune system targets foreign pathogens. In myasthenia gravis, it launches an antibody-mediated attack directly on the postsynaptic membrane of the neuromuscular junction. Looking closely at this cross-section, comparing a healthy neuromuscular junction to an affected one, the exact targets of this attack become clear. The immune system is zeroing in on the nicotinic acetylcholine receptors. The circulating autoantibodies physically wedge themselves into these receptor sites, acting as competitive antagonists. They block the natural neurotransmitters from delivering their chemical signals. Alongside this blockade, the presence of these antibodies triggers a complement-mediated immune response that actively destroys the tissue. This flattens the postsynaptic folds and permanently reduces the total density of available receptors. When the structural hardware of the muscle end plate is being actively dismantled by the body's own immune system, restoring motor function requires a method to work around the missing receptors. The first-line clinical response to this degradation is an oral medication called Pyridostigmine, often prescribed under the brand name Mestinon. Pharmacologically, Pyridostigmine is classified as a reversible carbamate acetylcholinesterase inhibitor. Pyridostigmine functions exclusively as a symptomatic bridge. It lacks the ability to stop the autoimmune attack or modify the underlying course of the disease. Instead, it manages the daily consequences of that attack. To manage these acute symptoms, clinicians must bypass the immune system entirely. They biochemically manipulate the synaptic environment to maximize the efficiency of whatever receptors the patient has left. To see how that manipulation works, we first need to look at the baseline mechanics of a healthy muscle contraction. When a nerve fires, presynaptic vesicles release a flood of acetylcholine molecules into the synaptic cleft. These molecules rapidly cross the gap and bind to postsynaptic nicotinic receptors. This binding triggers the electrical depolarization that tells the muscle fiber to contract. Almost instantly, an enzyme called acetylcholine esterase acts as the biological cleanup crew. It hydrolyzes the acetylcholine, breaking it down so the muscle can relax and prepare for the next signal. In the myasthenia gravis state, this precise system fails. The nerve releases a normal amount of acetylcholine, but because the receptor population is sparse and damaged, the signal diffuses before it can trigger an action potential. Pyridostigmine intervenes at the enzymatic level. The drug molecules bind directly to the active sites of acetylcholinesterase, effectively neutralizing the cleanup crew. With the primary degradation enzyme inhibited, acetylcholine begins to pool and accumulate in the synaptic cleft. This artificially prolonged dwell time allows a single acetylcholine molecule to repeatedly detach and rebind to the few surviving receptors, eventually forcing the membrane to reach the threshold required for depolarization. This binding is temporary. Pyridostigmine is a carbamate compound, meaning its enzymatic inhibition is reversible. This stands in sharp contrast to organophosphate nerve agents, which bind to the exact same enzyme but cause irreversible aging and permanent blockade. The relative safety of this drug lies in its molecular structure. Pyridostigmine is built with an ionized quaternary ammonium group. Because it carries this specific electrical charge, the molecule has very poor lipid solubility. It struggles to penetrate the blood-brain barrier, restricting its intense cholinergic effects almost entirely to the peripheral nervous system. By temporarily disabling the neuromuscular junction's natural off switch, pyridostigmine takes a weak, failing signal, amplifying it into a sustained pulse to restore motor function. While the molecular dynamics of pyridostigmine are highly effective, its clinical use is strictly bound by time. This graph plots the serum concentration of an oral dose of pyridostigmine over a 6-hour timeline, illustrating its narrow pharmacokinetic window. The onset is remarkably rapid. The drug begins inhibiting enzymes within 15 to 30 minutes of ingestion. The maximum therapeutic effect hits quickly, peaking right at the 2-hour mark, but clearance is just as fast. The curve decays steeply, and clinical weakness often returns by hours 3 and 4. This rapid clearance profile means standard once-a-day prescribing does not work. Patients require highly individualized, frequent dosing schedules to keep their muscles moving throughout the day. Current clinical guidelines suggest a conservative starting dose. For adults, this is typically 30 milligrams taken 3 times a day. From there, clinicians use a careful upward titration strategy, increasing the dose by 30 milligram increments every 2 to 3 days while closely monitoring motor response. There is a strict therapeutic ceiling. Some patients may require up to 120 milligrams every 3 to 4 hours. Exceeding this limit rarely yields any additional motor benefit and increases the risk of toxicity. Managing pyridostigmine therapy is a continuous, mathematically rigid balancing act. Patients and doctors must collaborate constantly to maintain serum levels within a tight therapeutic window. The primary pharmacological flaw of pyridostigmine is that it is non-selective. It inhibits acetylcholinesterase everywhere it can find it in the periphery. This chart divides the peripheral nervous system into 2 columns, showing exactly why that lack of selectivity is a clinical problem. On the left are the desired therapeutic targets, the somatic nicotinic receptors. Stimulating these motor receptors delivers the clinical benefits, resolving ptosis, fixing double vision, and restoring strength to the limbs. On the right are the collateral targets, the autonomic muscarinic receptors, which control smooth muscle and glandular secretions. Overstimulating these receptors produces severe side effects, like intense abdominal cramping, diarrhea, hyperhidrosis, and hypersalivation. To decouple these effects, clinicians often co-administer anticholinergic agents, like oral glycopyrrolate or hyoscyamine. These drugs block the muscarinic receptors without interfering with the nicotinic motor benefits. If a patient exceeds the maximum dosage limits, they risk triggering the most extreme consequence of therapy, a cholinergic crisis. This operates on a paradoxical mechanism. When excessive acetylcholine floods the synaptic cleft, it overstimulates the neuromuscular junction to the point that the receptors stop resetting. The muscle locks into a state of depolarizing blockade. Clinically, this presents as profound, flaccid muscle paralysis, accompanied by massive autonomic secretory failure, known as sludge syndrome, salivation, lacrimation, urination, defecation, GI distress, and emesis. Pushing the dosage past the biological ceiling creates a dangerous paradox. A medication meant to rescue the patient from paralysis instead acts as a paralytic poison. Looking at this clinical flowchart for myasthenia gravis, we see exactly where acetylcholinesterase inhibitors fit. Pyridostigmine sits at the absolute foundation, acting as a symptomatic bridge. It provides immediate relief while patients begin chronic immunotherapies, which take weeks to alter the underlying disease course. There is one major exception in this algorithm. Patients who test positive for muscle-specific tyrosine kinase, or MuSK antibodies, present a unique challenge. MuSK-MG patients typically show a very poor response to pyridostigmine and frequently cannot tolerate the side effects. Their treatment requires a rapid escalation straight into immune modulation. But for the vast majority of patients with standard acetylcholine receptor antibodies, pyridostigmine remains the cornerstone of their daily functional independence. The drug cannot cure the underlying immune dysregulation, but through a highly precise exploitation of synaptic chemistry, it buys patients their mobility and their lives back, while deeper, long-term immunological treatments take effect.